Well, welcome everyone. We can get started. Good morning, good afternoon, and good evening. My name is Victoria Trinice, and I am a health scientist at the U.S. Centers for Disease Control and Prevention, or CDC. On behalf of the CDC Foundation, and representatives from organizations working under the Conrad N. Hilton Foundation's Safe Water Strategy, we are very excited to have you join us today as we share implementation approaches and evaluation results from programs to improve water, sanitation, and hygiene in healthcare facilities in Burkina Faso, Ethiopia, Ghana, and Uganda, implemented between 2018 and 2023. First, a few housekeeping items. We will be using interpretation today. If you are most comfortable listening in English, please go to Interpretation menu on the bottom of your screen and select English. Pour nos collègues francophones, nous avons l'interprétation disponible aujourd'hui. Veuillez vous rendre dans Interprétation dans le menu en bas de votre écran et sélectionnez Française ou French. Also, please feel free to introduce yourselves in the chat. And we will be using the Q&A feature for questions today. Please feel free to ask questions for the presenters and panelists at any time using the Q&A feature. And then we'll have a Q&A session at the end of the webinar where we will try to get to as many of your questions as we can. Today's agenda will include a background of the Safe Water Strategy from our colleagues at the Conrad N. Hilton Foundation, followed by details on WASH in healthcare facility implementation approaches by representatives from several of the implementing organizations, followed by an overview of evaluation results presented by the CDC Foundation, and then our open Q&A. So with that, let's get started. I'd like to introduce Nabil Jamali, Senior Program Officer at the Conrad N. Hilton Foundation, who will provide a background on the Safe Water Initiative. Over to you, Nabil.
Thank you, Victoria. Can you hear me well?
Yes, we can.
Great, thanks. Thank you for the introduction, and thanks for the opportunity to present and share some ideas this morning. So I don't have slides prepared, but I'm just gonna say a few words about the Safe Water Initiative and our strategy going forward. So as you all know, we conducted a Safe Water portfolio review in 2023 to better understand the impact and the work that we have funded in the last 5 years across our 3 focus countries of Ethiopia, Ghana, and Uganda. Well, maybe it's important also to mention here that in 2020 or 2021, it was before I joined the Hilton Foundation, our board made the deliberate decision to phase out activities in Francophone West Africa, in Burkina Faso, Niger, and Mali, for security reasons. So currently, our Safe Water strategy is funding activities in Ethiopia, Ghana, and Uganda. So this portfolio review that we conducted last year is across those 3 countries, and we have identified different areas where there's room for improvement to amplify impact within our Safe Water strategy. I mean, there's a lot of documentation available on our website on that, and we had several webinars and convenings in country and online with colleagues to present these results and further brainstorm with government. So you can check all that. But the one thing I would mention was the lack of major focus on operation and maintenance. And this was identified as a weakness, and going forward, we are going to fund more activities related to operation and maintenance. Having said that, please note that our Safe Water strategy is not changing, so it is still the same, and we are going to continue funding within the same framework that was approved by our board in 2021. But there will be more emphasis on operation and maintenance. And specifically related to healthcare facilities, since this is the main topic of this discussion today, we see healthcare facilities and schools as part of a community or a district or a region or a service area where people should be receiving professional, sustainable, and affordable safe water services. And based on that, I mean, this is our definition of success. We will be looking more at solutions that allow the improvement of services and the delivery of professional safe water services to populations. So given, just in the interest of time, and I will just stop here, but I'm happy to answer any questions or provide further clarifications. But those are the main the key messages that I wanted to share today in line with this conversation. Thank you so much.
Thank you so much, Nabil. And wonderful. It is always makes me happy to hear about focus on operations and maintenance. And I think that's going to come up today as both a need and an area that partners have been working to support already. So next, we're going to dive a little bit deeper into the activities that were implemented under this work over the past 5 years. So the WASH interventions in healthcare facilities aimed to cover all public healthcare facilities in each selected district. So in each country, partners were working in one district and aimed to provide WASH service to all public health facilities in that district. And just to note, in Ethiopia, there were 3 separate districts that different partners implemented in each of those. The interventions implemented in these districts were intended to serve as a model for expansion that could be taken up by government. So model approach to full district coverage of WASH and healthcare facilities. And this was focused on WASH. Although the Safe Water Strategy is very focused on water, these activities did cover the other WASH domains as well. In each place where it works, the initiative is a partnership between many actors. Overall leadership and direction is provided or was provided by local governments and district health offices. Projects were implemented by a number of partners listed here, some of whom we will hear from shortly. And then technical support for needs assessments and evaluations was provided by CDC and the CDC Foundation with financial support from USAID. Additional technical support for water quality testing was provided by Aquia. Interventions in each of the districts were designed in response to the findings from baseline needs assessments and the interests and circumstances within each district. Because of this, interventions varied by country, but there were some elements that all partners conducted. These included distribution of supplies, such as hand hygiene supplies and waste bins, construction and rehabilitation of water supply, sanitation, and waste elimination infrastructure, and supporting trainings on key WASH and infection prevention and control, or IPC topics. Interventions were also guided by underlying quality improvement approaches. In Burkina Faso and Ethiopia, colleagues used the Clean Clinic approach, while in Ghana and Uganda, they used WASH Fit, or the Water Sanitation and Hygiene Facility Improvement Tool. As I mentioned, colleagues from several programs will present on additional intervention components that they developed in response to their specific project contexts. I'll start things off by highlighting just a few of the activities implemented by our colleagues in Ethiopia. There, they supported sewerage systems within the healthcare facilities. They developed protocols for WASH operations and maintenance, the word for today. They instituted systems for regular ward-based audits to assess WASH services. and they helped establish systems for conducting briefings on WASH and IPC to all new staff when they joined the facility. I will now invite Patricia Sanu, Project Manager at Catholic Relief Services in Burkina Faso, to share the approach that CRS implemented in Bamfora commune. This presentation will be in French, so all English speakers, if you have not already, please be sure to go down to the interpretation menu at the bottom of the screen and select English so you can hear the translation. Patricia, à vous.
Merci bien, Victoria. Merci pour cette opportunité qui nous est donnée de partager ce que l'ONG Catholic Relief Services a réalisé dans le cadre de cette intervention que nous avons nommée Saniaso. Le projet a couvert 30 écoles et l'ensemble des 17 formations sanitaires de la commune de Bamfora. Et cette commune est située dans le contexte, dans la région des Cascades, au sud-ouest du Burkina. Et le projet est également venu en appui à la mise en œuvre du plan stratégique WASH, eau, hygiène, assainissement de la commune de Bamfora. En plus des activités que Victoria a déjà énumérées plus haut, nous allons partager avec vous d'autres activités, donc activités complémentaires que nous avons eu à réaliser au niveau des centres de santé. Il faut dire qu'au niveau de chaque centre de santé, les communautés sanitaires ont constitué ce qu'on appelle comité WASH, comité eau, hygiène, assainissement, pour soutenir la gestion de la formation sanitaire aux côtés des agents techniques que sont donc les agents de santé. Et sur la base des améliorations que les différents centres de santé ont pu démontrer dans le suivi des indicateurs, le projet a pu réaliser des ouvrages, donc accompagner l'amélioration des services WASH en réalisant des ouvrages d'eau, des ouvrages d'hygiène, des ouvrages au niveau des formations sanitaires. D'autre part, avec les parties prenantes au niveau donc de la zone d'intervention, nous avons organisé des visites conjointes dans les établissements de santé. Et toutes les formations sanitaires ont actuellement la pratique de ce qu'on appelle auto-évaluation trimestrielle, où la communauté sanitaire se retrouve pour évaluer son plan d'action. Nous avons pu effectuer de façon annuelle le contrôle de la qualité de l'eau de boisson pour tous les sites, donc les 17 centres de santé. Et nous avons, donc le projet a pu mettre à disposition 3 producteurs de chlore de type Aquastream au niveau des centres de santé pour pallier les insuffisances du chlore. Et pour terminer, à l'issue de nos différents échanges que nous avons eus avec la mairie a pris un arrêté pour le financement des plans d'action des centres de santé à hauteur de 10% chaque année. Next slide, please. Pour ce qui est des leçons apprises, nous en partageons quelques-unes ici. Nous avons noté que les auto-évaluations sont l'occasion pour les communautés de l'ère sanitaire de voir comment leur plan d'action progresse et de noter des améliorations nécessaires pour atteindre les objectifs. Et ce sont des exercices qui améliorent la prise de décision au niveau de la communauté. Nous avons noté par ailleurs que les visites de suivi conjointes, donc avec les parties prenantes, les partenaires techniques, la communauté, les leaders, voilà, ces visites-là permettent d'améliorer le fonctionnement des structures de santé qui mettent en œuvre les recommandations et suggestions formulées à l'issue de la visite et des discussions sur les différentes composantes WASH. Nous avons noté également que le partage des résultats d'analyse de l'eau que nous faisons de façon annuelle permet de sensibiliser les populations au risque de contamination de l'eau de boisson et ça amène donc les structures sanitaires à prendre des mesures pour préserver la qualité de l'eau de boisson. Et sur la base de la mise en œuvre, nous avons noté également qu'il y a des facteurs de succès que nous avons eus. C'est la bonne gouvernance et la redevabilité, la participation communautaire et la mobilisation des ressources endogènes, la responsabilisation des parties prenantes et leur implication dans l'ensemble des activités. Comme dernière leçon également que nous avons notée, c'est en lien avec la pérennisation des acquis. Voilà, comme étape à suivre, c'est qu'il y a la nécessité pour la mairie et les partenaires techniques de prendre la relève des activités de suivi que nous menons jusque-là avec eux, afin d'assurer la durabilité des réalisations du projet dans les formations sanitaires. Voilà, je vais m'arrêter là pour l'instant et je repasse la parole à Victoria. Merci pour votre attention.
Merci beaucoup, Patricia. I will now invite Robel Wamisho, WASH Program Manager for World Vision Ghana, to share the approach that World Vision implemented in Asutifi North District. Robel?
Okay, thank you very much for the opportunity, Victoria. And good morning, good afternoon to all listeners. I want to share a few areas of what we do or what we have done as part of our WASH program in Asitufi North District with support and funding received from Conrad Hilton Foundation. Just to give a bit of initial introduction, we as World Vision implement our interventions in community settings and institutional settings. That is part of our design in terms of how we put our plans in the business plan. So as part of our institution intervention, we focus on healthcare facilities and then schools. I'm talking about what we normally do under our intervention in healthcare facilities. And then these are not exhaustive lists. I'm just highlighting, those who are relevant to the sustainability interventions and then activities that are contributing to maybe the topic of today's discussion. So I think for us, what we normally do and what we did was involvement of community members. We do not view healthcare facilities to be independent, institutions. We view them to be part and parcel of the community because they are there to provide services to the citizens. Accordingly, there is a clear discussion in terms of building that understanding between the community members and the healthcare facility workers. That is what we normally do. That will help us later on, in the process of bringing the various actors together to make sure that the project is well managed or the interventions are well managed. In terms of what activities we implement, the first key activity in terms of enabling us to provide safe water services is the solar-powered mechanized water system provision. Our mechanized water systems are solar-powered. They are environment-friendly and they are sustainable. They are provided with storage tanks. They are also provided with distribution lines. So that is one key intervention. And in order to, sustain the management of solar-powered water system or systems, we use what we call the pay-as-you-fetch model, where we train and then deploy vendors at water kiosks. And water is sold, as community members come to fetch and collect it. That way, whatever is generated will be, used to maintain and then successfully, sustainably operate the taps that are providing services to the healthcare facilities and education facilities as well within the same community. Because we have built that consensus from the beginning, as I mentioned, community members are working hand in hand with healthcare facility managers to make sure that management is provided all together, including the healthcare facilities within their community. So that is one key lesson. That is one area of success that we can talk as far as our intervention as Asitufi North is concerned. In fact, for the sustainability of the management model itself, we also work with the healthcare providers to develop, wash facility management plans where they indicate what are the needs, how are they going to address those needs, how are they going to liaise and work with community leaders in order to address the management of those facilities in a sustainable manner. So I think in brief, that is what we have been doing to make sure that the systems are sustainably managed in acetophenols and then other project areas. I can shed more light in case there are some questions that may come up later. Let me pause here and then hand it back to Victoria. Thank you.
Thank you so much, Robel. Wonderful to hear about the work that World Vision has been doing to ensure sustainability of and continuation of these services. And finally, I will invite Martin Watsitsi, Regional WASH Advisor from IRC WASH in Uganda, to share the approach that IRC has implemented in Kabarole District.
Thank you, Victoria, for the opportunity to share with all the participants in this webinar. I'm right now seated in Kabarole, and I'm sharing also some work that IRC has implemented mainly for WASH in healthcare facilities in the Kabarole district in Midwestern Uganda. Basically, with the Safe Water Initiative, actually our work was focused on supporting the district as a local administration to provide WASH services for all. That is households, health care facilities, communities, as well as the schools. And again, with the support under this very program, we realized that needed to be consolidated into a common vision, and that's what was developed into the Kabarole District WASH Master Plan 2018 to 2030. When you look at that WASH Master Plan, it provides at least a long-term vision that the district is striving to achieve, but a lot of details are on other areas of WASH. I think there was very little understanding on WASH in healthcare facilities. That is what was beefed up by the 2018 assessment of WASH in healthcare facilities with the support again from CDC that we managed to detail also that WASH in healthcare facilities. And we realized there were quite a number of gaps that needed to be filled. To come to a level of prioritization that prompted us to conduct a root cause analysis of why there was so much poor WASH in the healthcare facilities in Kabarole district. So that analysis was done with the district health officials, the political leaders, in charges of the healthcare facilities. I would say all of the key decision makers to identify, prioritize WASH investments in healthcare facilities. The idea actually was to start with the low cost but highly impactful interventions. And you will see like trainings, rehabilitations, drinking water were some of the interventions that were undertaken around that time. So again, the turnaround was to identify 5 model healthcare facilities spread across the district in which rapid improvements in infrastructure and the other behavior change activities were undertaken to ensure that these act as learning models for WASH and the infection prevention and control. So that those 5 so far have been added on with others, and they are acting as learning centers for the district. The issue of data was very important and was stressed in a number of engagements. So data portals have been created for the district, that the assessments that are done are monitored by the district officials themselves, and strategies for improvement are being developed. So like the improvement plans, they are all coming from these data portals, as well as the other engagements that we are having with the districts. Lastly, I would like to talk about one key important issue of capacity development, especially of management institutions, like the health unit management committees, IPC committees, that are able to carry out day-to-day supervision and monitor also the interventions to ensure that what has been put in place for WASH in healthcare facilities in Kabarole district is maintained, is improved, and at least there is a stronger voice that is carried around the district and beyond to bring about this desired change. All of these are compiled, also being based on the national guidelines for WASH in healthcare facilities that we have used to disseminate in the district and in other surrounding districts to create a national level advocacy and also a guided implementation of WASH in healthcare facilities. I will stop there and hand over back to you, Victoria. Thank you very much.
Thank you so much, Martin, for sharing IRC's approach and for yourself being such a very strong voice for supporting WASH in healthcare facilities. So now that we have heard about the great work that was conducted in these settings, the next question is, what impact did these activities have on improvement of WASH services and practices in healthcare facilities? I will briefly go over the methods that CDC and CDC Foundation used to answer that question. CDC designed a suite of evaluation tools informed by the JMP core and expanded questions and indicators found in WASH-FIT. The primary tool was a WASH survey that included an interview with the healthcare facility director or in charge on WASH management and direct observation of WASH infrastructure, which included water quality testing. Enumerators also observed healthcare worker hand hygiene practices. Enumerators shadowed healthcare workers and recorded their hand hygiene practice before and after contact with patients, 2 of the WHO's 5 moments for hand hygiene. Enumerators recorded whether the healthcare worker washed their hands with soap and water, used alcohol-based hand rub or ABH, or did not perform hand hygiene. And to reduce bias, observed healthcare workers were told that the enumerators were observing general healthcare practices and hand hygiene was not explicitly mentioned. In partnership with our implementing partners and local governments, CDC and CDC Foundation conducted baseline assessments between April 2018 and May 2019. Follow-up assessments were conducted in accordance with project timelines and occurred between June 2022 and September 2023. I do want to note that these end lines that we'll be presenting on here represent the end of one phase of the project cycle, and intervention activities have since continued in these settings. Our evaluation tools were similar between baseline and end line evaluations, and they were also similar across countries. I will now turn things over to my colleague, Carrie Ripke, a WASH specialist at the CDC Foundation, who will share the evaluation results. Over to you, Carrie.
Thanks, Victoria. So the number of healthcare facilities supported by the Safe Water Initiative and included in this evaluation varied by country and ranged from 8 facilities in Ghana to 33 in Uganda. The types of healthcare facilities also varied between locations, although most were primary healthcare facilities. Before we dive in, let me first take a moment to orient you on how the results will be presented for each of the WASH domains. For each domain, we'll present a chart showing the overall proportion of facilities at baseline and endline meeting each of the JMP service levels. So basic service, limited service, and no service. Then on the right-hand side of the slide, for each WASH domain, we will provide a breakdown of the proportion of facilities meeting the criteria for basic JMP service level at baseline, which is represented with a lighter color on top, and at endline, which is represented by a darker color on the bottom. With that framing in mind, let's dive into the results for each of the WASH domains, starting with water. So at baseline, 3 out of 4 healthcare facilities were providing basic water services, and this increased to 85% of facilities at endline. Looking in greater detail at the requirements for basic water service, we see that at both baseline and endline, nearly all the facilities had a primary water source that was improved, and this increased marginally by endline. We also saw an increase in the proportion of facilities with their primary source on premise, rising from 80% at baseline to 88% at endline, and a similar increase in the availability of water from the primary source at the time of the survey, rising from 81% at baseline to 90% at endline. Looking at these country-specific service levels provides us a more nuanced picture of some of the changes over time. We see that in Ghana and Burkina Faso, all or nearly all facilities were providing basic water services at both baseline and endline. In Ethiopia, there was an increase in the proportion of facilities providing basic water services. Although nearly all facilities had water from an improved source at endline, fewer had water on site or available at the time of the survey. In Uganda, we saw a more marked increase in the provision of basic water services, rising from just over half at baseline to 91% at endline. Endline tests of water quality at main water sources in Burkina Faso and Ghana found that E. coli was not detected in the majority of the 20 systems tested. However, E. coli was detected in 1/3 of the samples collected from boreholes with hand pumps. This highlights that just because a water source is improved, this does not mean that water from this source is safe, and that regular water quality monitoring is essential to ensure that water at healthcare facilities does not pose a health risk to those who use it. Moving on to sanitation, over the implementation period, the proportion of facilities providing basic sanitation services increased from no facilities at baseline to 13% at endline. At both baseline and endline, most facilities were providing limited services. Looking at the requirements for basic sanitation services, we see that the proportion of facilities providing improved, usable sanitation increased modestly from 74% to 83%, and that facilities made significant improvements in providing sanitation dedicated for staff and suitable for menstrual hygiene management and for people with reduced mobility. However, at endline, over half of the facilities still did not have a space appropriate for menstrual hygiene management, and over 2/3 did not have a toilet adapted for people with reduced mobility. Ensuring that everyone who visits a healthcare facility has access to sanitation that meets their needs is crucial for ensuring WASH services for all. While each country made gains in providing at least limited service, only Ghana had any facilities that provided basic sanitation services at endline. In each location, the majority of facilities had improved sanitation available. The greatest challenge or bottleneck to providing basic service in Burkina Faso and Ethiopia was the availability of a space for menstrual hygiene management, while in Ghana and Uganda, the more common bottleneck was the availability of toilets adapted for people with limited mobility. There were substantive gains in the proportion of facilities providing basic hand hygiene services. At baseline, only 4% of facilities provided basic service, which improved to 50%. At N-Line, 86% of facilities had appropriate hand hygiene materials, defined as either hand washing station with soap and running water or alcohol-based hand rub, or ABHR, available at a randomly sampled point of care, while only half of the facilities had functional hand washing stations at least one toilet. While every location improved their hand hygiene services over time, country-specific progress varied. The greatest gains occurred in Ghana, where no facilities were providing basic hand hygiene services at baseline, and 75% were providing basic services at N-Line. We saw the most modest gains in Ethiopia. At N-Line, availability of functional hand washing stations with soap and water near toilets, again, was that main bottleneck in each country. Diving a little bit deeper into the availability of hand hygiene materials in patient care areas, we see that improvements were largely driven by increased availability of alcohol-based hand rub, which rose from 13% at baseline to 60% at N-Line. The proportion of rooms with appropriate hand washing stations with soap also improved, though with a more modest increase. So we saw that availability of hand hygiene resources in patient care areas improved. But what about hand hygiene practices? We were only able to conduct N-Line hand hygiene observations in Burkina Faso and Ghana, so the results I'm going to talk through reflect these two countries specifically. Overall, healthcare workers observed hand hygiene practices improved from baseline to N-Line. The proportion of events where healthcare workers performed hand hygiene before patient contact increased from 21% at baseline to 41% at N-Line. And the proportion of events where healthcare workers performed hand hygiene after patient contact increased from 34% to 60%. Alcohol-based hand rub was the most common hand hygiene material used at all moments, underlining the importance of sustaining access to ABHR to facilitate hand hygiene. At both baseline and N-Line, healthcare workers performed hand hygiene more frequently after patient contact than before patient contact, highlighting a gap to be addressed in future education and behavior change programs. Looking at waste, overall, we saw a slight increase in the proportion of facilities providing basic waste management services, increasing from no facilities to 10%. The majority of facilities were providing limited waste management services at both baseline and N-Line. We observed large gains in the presence of appropriate waste bins in a randomly sampled point of care, although less than half of facilities met this criterion at N-Line. Facilities performed better at safely eliminating sharps waste through disposal in an incinerator or a lined covered pit, or transporting for offsite waste disposal. Overall, the largest bottleneck to providing basic waste management services was the safe elimination of infectious non-sharps waste. At N-Line, only a quarter of facilities were safely eliminating this type of waste, although this was an improvement from 12% at baseline. Ghana, Burkina Faso, and Uganda all had facilities that were providing basic services by N-Line, and a majority of facilities in all countries provided at least limited service. Like we said previously, elimination of infectious non-sharps waste was the most common bottleneck to achieve basic service level in all countries, except Uganda, where the main bottleneck was appropriate segregation of waste in patient care areas. The final WASH domain we have is environmental cleaning. The JMP service ladder for environmental cleaning had not been established at the time we collected baseline data for Ghana and Ethiopia, so the baseline metrics presented here do not include those facilities. With that in mind, we saw that generally the proportion of healthcare facilities providing basic environmental cleaning services had increased over time from no facilities at baseline to a quarter of facilities at N-Line. The proportion of facilities not providing environmental cleaning services also dropped from 78% to 12%. When looking at the criteria required for basic service, we see that gains were made both in the proportion of facilities in which all cleaning staff had received training by a qualified trainer or supervisor, and where cleaning protocols were available, although significant gaps remained. Looking at each of the project countries, we see that at N-line, the proportion of facilities providing basic environmental cleaning services ranged from none in Ethiopia to half in Ghana. In Uganda, the most common bottleneck to providing basic services was lack of training of all healthcare workers or those with cleaning responsibilities at the facility. And in other countries, lack of protocols or policies was the more common challenge. So that was a really detailed picture of how the Safe Water program impacted WASH services and practices. In summary, at both baseline and endline, facilities performed the strongest in providing basic water services. Nearly all facilities were using water from an improved source. However, some facilities were using off-site sources, sometimes due to breakdowns of their on-site sources, and some did not have water available at the time of the survey. These challenges speak to the importance of appropriate operations and maintenance of these water sources, which is essential to ensure that these gains in service provision persist over time. Our largest gains in providing JMP basic services were seen in the hand hygiene and environmental cleaning domains. Progress in the environmental cleaning domain was largely driven by that improved training of cleaning staff, an essential requirement that has historically often been overlooked, particularly in lower level healthcare facilities. Improvements in the hand hygiene domain were largely driven by increased availability of hand hygiene supplies, particularly alcohol-based hand rub at points of care. This increased availability, along with implementing partners' behavior change and capacity building activities, likely contributed to the improved hand hygiene practices we observed. It is important to note that these gains in availability and use of hand hygiene resources may have also been bolstered by other initiatives that occurred in the project districts in response to the COVID-19 pandemic. Facilities had the greatest challenges in providing basic sanitation and waste management services, although there were gains in providing basic and limited services for both those domains. The basic service levels for these domains are fairly complex and may mask significant improvements brought about by the project, particularly in the quality of sanitation infrastructure and availability of on-site incinerators that facilitated timely disposal of Sharp's waste. So, I am now going to ask each of our speakers to turn back on your cameras. And I'll open the floor for anyone who has questions. So if you have not already, please add your questions to the Q&A box. If you see a question in the Q&A box that you are interested in hearing the answer to, please use that upvote function so we can prioritize answering some of these questions. So with that, let me stop sharing and get into the Q&A. Right.
Thanks, Carrie. And as we're waiting for people to think through questions, there is one that is in the chat that was for Patricia that I think she may be answering, but just for, since it was in French, the question from Usman is that Patricia mentioned establishing an agreement with the mayor's office. Oops, I just disappeared. With the mayor's office to finance 10% of the health facility action plans. And the question is whether that agreement has been fulfilled yet. And it also whether there are any local resources that have been able to be used for Washington healthcare facilities. Patricia, I don't know, would you like to answer that out loud?
D'accord, j'avais commencé par répondre par écrit, mais je vais répondre et compléter ici. Voilà, pour la première partie de la question portant sur... La première partie de la question porte donc sur l'accord avec la commune. Il faut dire qu'à ce niveau, la mairie a pris un arrêté qui l'autorise donc à pouvoir appuyer la mise en œuvre des plans d'action des centres de santé à hauteur de 10%. Voilà. Donc, en fonction du montant du plan d'action, 10% seront donc attribués à la commune. Et cet arrêté a été signé, validé par la mairie, et il ne reste que la mise en œuvre. Et la commune se prépare donc elle cherche les fonds, elle cherche à mobiliser les fonds pour pouvoir répondre à cette attente-là, voilà, d'ici l'année à venir. Le deuxième aspect de la question a porté sur la mobilisation des ressources endogènes. Il faut dire que pour la durabilité de ce cas de projet, voilà, des projets de ce genre-là, il faut assurer la relève. Voilà. Après la fin du projet, qui finance les intrants, qui finance l'entretien, les réparations des infrastructures pour le maintien du service. Donc, il faut aller à la mobilisation des ressources endogènes. Amener les communautés à s'asseoir ensemble, à décider de cotiser, à faire appel à leurs enfants qui sont ailleurs, à faire appel à des aides, voilà, pour qu'en dehors du projet, les projets et les activités puissent se maintenir. Les activités de gestion, comme je disais, mais également les activités de suivi qui doivent être réalisées par les structures techniques avec l'accompagnement de la mairie. Donc, c'est à ce niveau que le besoin de ressources endogènes est nécessaire. Et beaucoup d'efforts de mobilisation ont été faits déjà pendant le projet et nous avons foi que les bonnes pratiques seront maintenues dans le post-projet. Merci.
Merci.
And there is a question in the chat specifically for Martin that I will first pose to Martin and then ask a different question slightly for the rest of the group. So this question was, Martin, could you please describe the process for the root cause analysis that was used to develop plans for healthcare facilities in Uganda, and what were the results? And then for others, if you could be thinking, how did your district or area prioritize interventions based on the data from some of these evaluation activities? So first, over to you, Martin.
Thank you, Carrie, and thank you, Shamila, for the question. The process was to engage. Actually, we used the results of the assessment as a background information that was shared with the, as I had mentioned, the district health officials, the in-charges or the heads of these healthcare facilities, as well as some political heads at the district. Our major target was those who can make decisions that would lead to improvement. So we disseminated the results.
I think, unfortunately, we may have lost Martin. While we're waiting for him to maybe come back, Robel or oh, okay, I see him here again. Let me see if I can bring him back. Martin, are you able to hear us?
I'm sorry, my network just kicked me out, so I don't know how to proceed, whether I continue or you had moved on.
We had not yet moved on. You returned just in time. So if you'd like to finish what you were sharing there.
Just in a moment. So we engaged in a 2 days process, a 3 days process actually, to identify that each of them with a scorecard of how they had performed in the assessment was looking at what is really the problem and what is at the bottom of this problem. If it was a poor waste management, why was there poor waste management? And they were able to come up with the reasons, but also the possible solutions. And the results, I would say, were the improvement plans that were developed that are being implemented. And periodically, we go back to follow on what has been achieved alongside those improvement plans. Thank you very much. Back to you, Carrie.
Yes, thanks, Martin. If Robel or Patricia, either of you would like to speak more about how data was used to inform some of this participatory decision-making.
Okay, thank you, Kerry, once again for the opportunity. Well, I mean, data, of course, translate into information, as we all know. The gaps that were identified during the baseline evaluation were inputs for us to design our intervention in terms of addressing the needs of specific healthcare facilities. Some of the healthcare facilities needed maybe a little bit of upgrading of the existing infrastructure for the wash services to function fully. And some others needed maybe new interventions in terms of what we intend to do. So we used that initial information, and then also the master plan, you know, the district master plan. We are intervening under the auspices of the district universal wash master plan, which also gave us clear information in terms of identifying some of the gaps, and then informed our plan to design relevant interventions. I think that is in general what we have been doing, and then how we have been able to reach the needs in those healthcare facilities, working along with partners, of course. Thank you very much. Back to you, Kerry.
Great. Nabil, I don't know if you want to speak at all to how the Conrad N. Hilton Foundation more broadly is using data and information to inform your activities. I know you highlighted some of this in your introduction.
Yeah, thank you. I mean, what I would say here is related to data. We, of course, data is very important and crucial to our work, but all the data that we have is basically generated by our grantees and our partners. So data is definitely key in informing learning for the sector. You know, and maybe it's important to note here, because of our legal status and the requirement to only keep a charitable purpose for any work or any funding that we provide. So there's no data that's only for the Hilton Foundation's use or consumption. So everything is generated by grantees and partners. Everything is used for to inform the sector and advance the sector. Definitely, there's a lot of data that our grantees generate that and use for their own measurement or day-to-day work. As far as we are concerned, the data is mainly to inform what additional learning or additional funding is required to clarify or inform important areas or priority areas in our learning agenda, and also definitely report to our board against our 5 strategy goals that are mentioned in the Safe Water Strategy. So this is how I would summarize our use in data. I mean, a final point, sometimes we also fund specific activities to generate a piece of data because we know it's important for the sector or for any learning. So yeah, I mean, it's all central, but there's no data only for our internal use. Thank you.
Great. Thank you so much, Nabil. And so thinking about data and use of information, just wanting to highlight that again, as I put in the chat, this webinar is being recorded and we will be sharing the slides and recording. In the near future, we are also in the process of finalizing a sort of written report that summarizes this information and a bit more information in detail that we will also be sharing here in the near future. So with our eyes to the future, I want to ask one question for each of our panelists here. In about 30 seconds, could you tell us what is next for WASH and healthcare facilities in your district? So Robel, I see you first, so I'm going to put you on, you have the first opportunity to share.
Okay, so the future for WASH in healthcare facilities in our case is we continue to prioritize. Healthcare service cannot be provided without WASH interventions and then WASH services that are attached to healthcare facilities. So we understand that basic principle, that basic reality. And as part of our business plan, we always prioritize WASH in healthcare facilities as a means of addressing the needs of healthcare facilities. So it will continue to be our priority, not only in acetophenols or in the HAFO region, but also other areas of our intervention. And this will be guided by the overall strategy and then the WASH business plan of World Vision Ghana. So we are hoping to work with partners and also other, actors within the sector to bring safe water and sanitation services in healthcare facilities. Thank you. Back to you, Kerry.
Martin?
Thank you, Carrie. For us, I think the next is to continue using this data as generated evidence for our advocacy and continuous engagement of key decision makers to make improvements for WASH in healthcare facilities. Just to give a detail about that is that last week, the hard copies of the scorecards were shared in the district, and in Kabarole, on the 2nd July, the district health officer has already called all the in-charges, not only to disseminate again these, but also to focus on the no service areas in order to update the improvement plans and identify solutions for improvement. So that's what I can say, that we are continuing on the journey of improvement.
Wonderful. Thanks so much, Martin. And Patricia, to close us out.
Ok, merci. Donc, à la suite des autres, c'est dire que nous allons continuer nos interventions dans ce domaine. Il faut dire que les parties prenantes, l'ensemble donc des parties prenantes du projet sont convaincus du bien fondé de cette intervention. CRS, donc notre ONG, est convaincue de la pertinence de cette intervention. Et avant même la fin du projet Saniaso, CRS avait un autre projet WASH dans une autre région où ils ont on a introduit donc l'aspect, le volet donc intervention dans les centres de santé avec l'approche centre de santé propre clean clinic. Il faut dire que c'est vraiment très pertinent et nous avons besoin de regarder tout cela. En plus de nos interventions WASH dans les communautés, dans les écoles, il y a la nécessité d'intervenir dans les centres de santé pour accompagner cet aspect de la gestion du WASH. Merci.
Wonderful. Well, thank you again to everyone for joining today, and a special thank you to all of our presenters and panelists. We're grateful for you sharing your insights. Again, thanks to all our attendees that were able to join. And like I said, we will be sharing some follow-up materials shortly. Have a wonderful rest of your day, everyone.
Thank you, everyone.
Bye.
Thank
Bye.
you. Bye-bye.